appointed members and their terms. Just want to point out that this meeting does serve as the Rules Advisory Committee for the rules for prior authorization and PDL recommendations to the OHA. As such, the OHA will entertain comments in terms of that RAC at the end of the meeting. But again, anything we discuss here today may result in changes to PDL or PA placement. Conflict of interest declarations. All the committee members have signed a conflict of interest declaration that's on file with the Oregon Health Authority. Staff similarly keeps theirs up to date and have filed those with the Oregon Health Authority. Any changes to those are expected to be made with the OHA or to be disclosed at this time. So for the committee, any conflicts that you haven't previously disclosed that you need to air right now? Fantastic. So we have the approval of the agenda and minutes. I sent out the minutes from the previous meeting to the committee so that you could review those in advance. They're also included in the packet on pages 5 through 10. So we'll take action on that in just a moment. One comment for the approval of the agenda. Under the consent agenda, we previously stated that the state annual report was going to be included. That is not going to be presented. It's not going to be included at this time, so that's struck from the consent agenda topics. Also, we have another robust agenda, as we typically like to put in front of you. So we reserve the right, depending upon how far we get into the agenda at the break. We may take the Gaucher disease class review, which is right at the break at 3:15, and move that into the last place, as that's the one topic we may want to defer if we do need to defer it. Hopefully we'll stay on pace and won't need to do so, but just wanted to bring that to your attention. So with that, with the minutes, are there any edits or clarifications that need to be made? And if not, we need a motion to approve. Move to approve.
Okay. All those in favor?
Aye.
Aye. Any opposed? Anybody abstaining? Okay. Approved as presented.
And with that, we'll turn it over for a department or OHA update from Trevor Douglas.
Hi, everybody. I just want to say thank you, first and foremost, for volunteering your time. I know I say that probably often, but I do genuinely thank you for taking the time out of your busy schedules to be here for the folks that are on the fee-for-service program for the Medicaid program in Oregon. I have one announcement. It's less for the committee, but important for you to know, and more for the crowd. So I'm going to try to speak up and use my karaoke voice. I just want to be sure that everybody knows that House Bill 2692 actually changed timelines for and by which we, the P&T committee, operate. So just to be clear, I'm just going to give a little brief snippet so that you can kind of know what that timeline looks like. Again, 2692, it's a House bill. That is the one that you would want to go and look up on Google to find. And it's relatively easy to find. And if you need help, you can always email me. Essentially, 7 days after a recommendation is made, those recommendations will be posted to the P&T OHA website. Then as soon as, usually at that time, this happens at the same time, the director is also given approval at that time. We try to do that, but in the case, in events where that doesn't occur, we'll also post a director-approved set of recommendations or modified recommendations if the director so chooses to make amendments or disapprove of a specific decision. Once that's posted, nothing generally can take effect until 7 days following that. So nothing less than 7 days has to pass before implementation of those recommendations. During that period of time is the time that if a interested party is interested in asking for that decision to be reconsidered, that is the window that you have. So just wanted to make sure that was clear and that was conveyed clearly. Hopefully I didn't completely confuse everybody. Other than that, I have no other significant... well, Roger's pointing at me saying that I need to say something.
Final meeting for members.
Oh, expirations.
Yes, final meeting for members. We do have to say goodbye to... I think it's Kelly's on the phone, isn't she?
Kelly's on the phone.
Right. So thank you, Kelly, very much for all of your service. I know it's been difficult, particularly in the last little while, for you to make it in person, and we totally understand. But thank you for your service, and your time here on the committee is valued and appreciated. Likewise, Dave, passed. I believe your term is also ending. However, it may not. So we will find out shortly. I believe that your name has risen to the top of applicants for reappointment.
And similarly, Stacy Ramirez's term is ending. She, too, has thrown her hat back in the ring to be considered for reappointment. And so that's in the hands of the OHA to evaluate that.
Right.
Great. Any questions for Trevor? Okay.
Can you remind us, Trevor or Roger, for those of us who are in the 2020 camp, when would you like to hear whether we're interested in reapplying or not?
Anytime.
Okay.
Great. And again, for the public, if you're aware of parties that might fit the bill for being a prescriber or a pharmacist actively in practice, the OHA does have an application that they're open to receiving applications throughout the year, and those will be considered for placement on either the P&T committee or the Mental Health Clinical Advisory Group.
Yeah.
Or did I take your...
No, that's perfect. I would say if you are going to resign your seat, you have to have an adequate replacement ready to submit an application. Just say.
All right. The next section of the agenda is the consent agenda. It starts on page 11 in the packet. We have our quarterly utilization cards. Those are pretty standard. The committee has always seen those. We also have our anti-phone class update and anxiety class update. We have no public comment, so we just need a motion to approve that section. We'll be reviewing an executive session and then coming back out after executive session to discuss potential changes to the PDO.
All those in favor? Aye.
Aye.
Any opposed? Okay, motion passes.
So DUR, the P&T committee also serves as the federally mandated DUR board, which is required to meet quarterly. We focus one meeting each quarter on DUR activities, as you're aware. We last did that in July. This being the only meeting in fourth quarter. We have DUR functions. So starting on page 77 in the packet is the ProDUR report, and we'll turn it over to Rich.
All right. Halfway through the packet already. Page 77. This is just an overview of our prospective DUR alerts for fee-for-service Medicaid during third quarter of 19, July through September. This chart just shows the number of alerts you get, how many times pharmacists overrode it, or canceled it, or did not respond. Most of the time they don't respond. The only two alerts that actually deny claims are the early refill and the pregnancy, which then require an action by the pharmacy if they wish to override it and move forward. So early refill is by far the highest volume of pro-DUR alerts that is set, but we have a relatively low override percentage, 17%. The next page shows some of the drugs that have the highest volume of early refills, as well as some of the controlled substances that we just kind of keep track and watch over. Looking at the alerts overridden, I've highlighted a couple for the oxycodone and buprenorphine and naloxone, but considering how small volume of actual alerts and claims that we have, it's not a huge amount, relatively. And there were no issues to point out or anything that raised the eyebrows specifically. The last page is just a breakdown of the reasons for the early refills, looking to see if there's trends or abuse of getting vacation lost overrides. Relatively small percentage. I'd say that 10% of the lost is a little bit higher than normal. But by far and large, the early refills are usually being overridden because of therapy change or medically necessary. And that's all I have.
Rich,
Yeah.
benzodiazepines are usually pretty in the top there. What do you think are non-proteins a little higher or non-benzodiazepines are a little higher?
They have dropped quite a bit, but so has the volume of claims. I think the biggest thing is putting the benzodiazepine restrictions is that we used to see the claim screen used to be in the 20,000 range. Now they're down to the 8 to 11,000 right now. So we've seen a huge drop off in the volume of visiting scripts over the last several years.
Other questions for Rich? So after prospective DUR, we also look at retrospective DUR. It's a function of our team. I unfortunately included the Retro DUR report that we previously reviewed in July. So in front of the committee, I did a printout. I also posted the fourth quarter Retro DUR report on our website. So in the audience, you can review that through our website. One final thing, as I turn this over to Dave to go through the Retro DUR report, I made it very challenging as each of your packets have been stapled together in a different order. So Dave will have to call out which section of the Retro DUR report he's discussing so you can follow along. Apologies. That's right.
All right. Well, thank you, Roger. So if you grab your packet and take a look at the first page would be the change form initiatives. Those are some past ones that we've done. We've prioritized some of the most successful ones over the past year. We plan to bring some new opportunities to your attention in the new year and some new methods that we have. So excited to be able to do that in the near future. You turn the page, hopefully, you'll find the dose optimization and the associated cost savings with those opportunities. It gives you an idea of the number of claims that were identified, faxes that went out, and a running total. So we keep track of that over a year's time from the initiative when the fax went out, and so that number accumulates over time, and so you'll see the cost savings associated with those. And those are largely a lot of mental health drugs and things of that nature with a lot of utilization that the service covers. If you turn to the next page, antipsychotic use in children. These are our expert consultation referrals. This was an initiative that we previously presented to TNT. And so you'll see the number of patients that were identified and profiles that were sent out to our expert reviewers at Local K. And so we also notify the prescribers that these faxes have gone out and to hopefully engage with Local K for safer prescribing for long-term antipsychotic use in children, multiple prescriptions of psychotropics, and potentially for glucose monitoring, etc. So some of the numbers for that. If you go to the next page, it's...
Yeah, no.
Yeah,
sorry.
I'm sorry, before you move on, because the numbers don't really add up. 67 profiles sent, there were 3 patients who changed, as a consequence of that, and then 41 who continued. But it seems like 60 prescribers were notified. So I'm just wondering, did some patients just simply discontinue, or wouldn't that be shown up as a change in the psychotic therapy?
So they don't quite add up. One reason for that might be if patients were subsequently unenrolled for Medicaid, so they don't have a change in their antipsychotic medication, but we might no longer include them if they're no longer enrolled in Medicaid. That's just one thing that comes to the top of my head. We don't, so that what's included in those that have a change in their antipsychotic drug is a change in the drug, a change in the dose, or discontinuation, but still enrolled in Medicaid.
Would also patients that were identified and done in a referral towards the end of the quarter not have been in that 90-day period, so not reported on yet? So what I'm hearing from you is interested to know how we get the numbers aligned where we have and find an additional bit of data. I think the big takeaway here is that from the recommendations we brought before you, looking at kids of a younger age that are on chronic antipsychotic therapy, then those that we winnowed down, that we referred for review, right, that very few were changing the therapy. So often that they're, I think, and we do have a follow-up meeting with OK to discuss what they're seeing as far as the impact of this and whether or not there might be appropriate prescribing. It's just that they've got to this point, and so it might be further down the chain. So we'll report that back.
The reason I ask is because I've traveled this road. So
Travel the road of
the intervention from the reviewer to the prescriber it results in very, very few
change in practice.
And there's different approaches. So that was the reason I was interested because, like I said, I know this road.
Yep.
And we'd be definitely interested in new ideas and new approaches that things that come up. We'd love to hear different ideas and improving this process as well. So definitely appreciate your input. I believe the next page would be the non-adherence antipsychotics for schizophrenia. This was presented in May of 19 to the P&T committee, and this is a notification. These are patients that are identified that have been non-adherent to these important therapies, and so we get a notification out to the provider that the patient's 15 days or more late on filling their antipsychotic. So those are the numbers of facts that went out, and keep track of basically if there's been any uptake or change in claims with a different antipsychotic or patients with claims for the same one in the next 90 days. So once again, there's lots of opportunities to reach out for adherence, and we're looking for more improved ways to get the message out, and we're happy to provide that kind of data. Profile reviews are on the next page, and there's a variety on there. Toward the top would be the children on antipsychotics or multiple psychotropics. Those are mostly our kids in foster care. So those messages go out to the various prescribers, and actually these ones actually go out to Opal K, and so it keeps the children on their radar so they can engage with prescribers. We also have the high-risk and regular polypharmacy patients, and the number of profiles that are reviewed and sent out, and responses, as well as our lock-in program. So do you have a question on that?
How do people identify for lock-in?
Yeah, so we are discussing ways that we can maybe change that up, or possibly focus in on the more actionable patients. But basically, these are patients that have a history of drug or alcohol abuse, tobacco abuse, conditions that are induced by drug or alcohol withdrawal, and also on certain key medication classes, of course, opioids, but not limited to just that. Also benzos. So they have to have a multiple risk factors to show up on our radar, and or it could be patients who in the last 6 months were on more than 40 milligrams a day of methadone, currently on methadone and benzo. So it's a hodgepodge of a lot of key factors that we would want to get eyes on these patients for potential for either abuse or misuse, and be able to lock them into prescriber.
But not surprisingly, our numbers go down as we notify or understand there might be problems with benzodiazepines. We have PA criteria. We decrease our utilization of benzodiazepines. We have opioid PA criteria. We have 7-day pills. So drugs of concern. We also have utilization controls, which decrease those claims. So as Dave said, we'll look for other opportunities to identify members that might benefit from having a lock-in. So it isn't surprising that we see the numbers go down because it's reinforced by some of our other tools.
One quick follow-on comment. We had some experience when we were doing lock-ins that when we asked a question to the member, is there anything we can do with you using a lot of pharmacies or needing extra medications that may be unsafe? Can anybody on our end work with you on helping you and going over what's going on and kind of a care coordination offer? And we found it to be highly sensitive to people who wanted to participate and talk and get help weren't the people we were worried about, but there was always something interesting going on that the claim process and the data couldn't quite capture. But the people who didn't want to participate at all, either all of a sudden disappeared, stopped their behavior, or we had to do something more definitive. So I just throw that out for thought.
The final is the safety net program, and we presented, one of those is the combination opioid sedative that was presented in July of 19, and we've got the number of patients identified and prescribers that were notified of the combo. So it's a safety aspect to try to notify and hopefully change prescribing in those cases, as well as down there we have ICS and LAVA, so patients that we're on these are patients that are in need of a controller medication, and they have been denied a particular controller medication for whatever reason, and they did not follow up with a fill. So we try to reach out to prescribers in that case and let them know that the patient's still in need of controller medication. So that is our retro DUR report. And once again, if you have questions or areas that we could explore or expand, I will be happy to entertain those.
The only question I have is we always talk about prescribers successfully notified. I'm not really sure exactly what that means. Does that mean that we send a letter to them, or does that mean just an acknowledgement, get something back, or does it mean it's a phone conversation?
Yeah, we get confirmation that the fax went through, but yeah, we
So it's
What happened with the fax
was received. Yeah. What happens after that is completely
Good question. It is challenging. And we also, but the flip side of that is we try to automate some of these, so if we can identify something electronically and use the fax numbers to send out information, it's casting a wider net. So
But we don't necessarily have staff that follows up on the faxes or anything like that.
not on the individual, that's a huge volume, and as you saw on the previous one, little ROI or people that are responding. So one additional component of drug use review is educational initiatives the state undertakes. One of the ways that we do that is through our Oregon State drug reviews. Kathy Centeno on the phone is our editor, so I'll turn it over to her and direct your attention to page 86 in the packet.
Thanks, Roger. So yeah, we had a couple new newsletters that are included there in your packet. The first one is a summary of the Oregon Health Authority Mental Health Clinic Advisory Group recommendations for schizophrenia. And then in August, we posted a newsletter on stimulant use in excessive somnolence disorders. It's also very informative. We continue to send the newsletters, the drafts, to the committee for feedback, and we really appreciate your helpful comments. This month, you might have seen that we posted the newsletter on updates on recent guidance and safety alerts for opioid use and non-cancer pain. So I encourage you to take a look at that one as well. And then in the pipeline, we have a newsletter on CDRP inhibitors for migraine prophylaxis. At this time, I'd also like to solicit the committee for any topics they think might be of interest to our providers.
chance for you right now. Any topics that come to mind you'd like us to go explore? Or... And if not, again, always welcome. You can shoot me emails, shoot me Kathy. Topics that we'll look for. A lot of times the topics or reviews we bring sometimes translate into materials, so we'll continue that process. But if you do think of timely pertinent subjects, please bring them to our attention.
I'll toss one in, just because it was top of mind from the presentation this morning, deprescribing, if we haven't done that in a while.
Deprescribing.
Reach out to Leah Gora is on our team, who's just done some work in that space.
Great, thank you, Jim.
Great, thank you, Kathy.
And then, of course, if you don't get our newsletters, you can sign up on the website to receive those electronically.
Again, just a reminder of that on our website. You can sign up on our listserv and you pick and choose what you'd like to receive. Notification of the newsletters, also notification of meeting materials when posted. So highly encourage everyone to take advantage of that listserv. All right, forging on, we have our substance use disorder, alcohol, and that. We'll start with the literature scan starting on page 92 and turn it over to Deanna Lentz.
All righty, are we going to put the slides up?
Yes.
Okay. Well, while she's doing that, I will just remind you that we just recently reviewed substance use disorder in January of 2019, so there wasn't a whole lot of evidence to sift through. There were two systematic reviews from the Canadian Agency for Drugs and Technologies, or CADTH. So the first one was a rapid response report from April, when they looked at the different formulations of buprenorphine to see if there was any differences in outcomes, and no clear patterns emerged regarding the comparative clinical effectiveness of, say, the buprenorphine buccal film versus the extended release injection versus the subcutaneous implant or the sublingual tablets. And then the second systematic review was looking at buprenorphine during pregnancy, which there was limited evidence that was of limited quantity and quality, and the basic conclusion was that there really is not enough evidence to evaluate treatment for opioid use disorder with buprenorphine in pregnancy. The other thing, there was two recent new drugs that were approved by the FDA. The first one is the buprenorphine naloxone combination, Zasipa. And basically, that's just a higher dosage strength of Suboxone. It's a sublingual film that's 16 milligrams, 4 milligrams. It is currently in under a patent dispute, so it hasn't reached the market yet, even though it was approved in September 2018. And the other product, the Redaxi, which is an extended release formulation of buprenorphine for sub-Q administration that can be given weekly or monthly, received approval last December 2018. But that one is also being held up due to some patent disputes because Sublocade was initially approved as an orphan drug, and that was recently reversed. So I think now that that's changed, Redaxi can be marketed. It won't be able to be marketed until November of 2020 when Sublocade's clinical exclusivity period expires. So based on the literature review, we don't have any recommendations for changes to the PDL, but I will turn it over to Sarah to talk about some of the new legislation initiatives that have transpired this year.
Yeah, so in the last legislative session, some legislation passed in Oregon that prohibits use of prior authorization during the first 30 days of medication-assisted treatment for both opioid and alcohol-related substance use disorder. We do have a couple currently non-preferred drugs for opioid use and alcohol use disorder, which are non-preferred and do require PA currently. Those are listed here on the slide. As a reminder, all the buprenorphine products do have a REMS program for prescribers. And in a recent policy evaluation that we did of this class, Most of the patients, so 86%, had an appropriate diagnosis of opioid use, opioid dependence, or opioid abuse based on claims history if they were prescribed buprenorphine. Currently, the majority of the use for buprenorphine products and alcohol-related substance use products are for preferred agents, and there's only a small proportion of patients who have prescriptions which exceed a 24 milligram per day dose. There were three patients that we identified in the quarter that we looked at that had approved but had subsequent paid claims for an opioid therapy, which may indicate that that delay in PA, at some point during that delay in the PA, between when they got a denied claim, between when the PA was approved, and they didn't go back to the pharmacy to get a medication after that, even though they did have an approved PA. So the recommendations, again, as Deanna reiterated, there's no recommendations based on the clinical evidence, but to comply with the new legislation, we wanted to designate all these products as either preferred or voluntary non-preferred, based on costs in order to avoid having a PA within the first 30 days of therapy. So we'll remove the PA requirement for all of the opioid use disorder products, except if the dose exceeds a limit of 24 milligrams per day for those transmucosal oral products. And then continue to monitor this class to make sure these therapies are being prescribed appropriately. Any questions?
Questions for Sarah or Deanna?
So is it required when the prescriber bills that they have like that special DEA number in order for it to go through? Or
It's not confirmed on our side. We require the provider to have their NPI enrolled in Medicaid for coverage. But I think that's a component of pharmacies that are filling prescriptions that they're confirming the XDA.
I have another question just in terms of like the usage patterns. You know, you've had a few people who there were PAs who were authorized but they never refilled the Medicaid. What's the general discontinuation rate for patients once they started on these? Like, you know, how many fills will they have before you stop seeing the claims continue?
That is a good question, and I don't have the data right in front of me. I know that was something that we looked at when we last did our policy evaluation, and I was surprised at the proportion of people that had more than 6 months of therapy. So the rates were higher than I was expecting that had continuation therapy. But I don't have specific numbers for you right now.
When you guys were seeking to harmonize this PA process with the intent of the legislation, did you work with MAT providers on this response?
So we didn't work specifically with prescribers. I know we had talked, the OHA had talked with several other insurance companies, including Kaiser, and so may have gotten some input from prescribers during that process, but no, I hadn't worked directly with any prescribers.
The reason why I bring it up is a couple of people who kind of devote themselves to this space have brought up the observation that a number of these treatments don't really have strong evidence. ICER hasn't found them to be effective. And we don't know which subpopulation sees them correctly, and these are people who are advocates of MAT treatment. And so I do wonder, even, so there's the first 30 days, I completely get that, but then there's what happens next, and I guess I'm advocating as a TNT committee member that we go have a conversation with, like, for example, the OSHU ECHO program is training primary care to do MAT on what is best practice right now, and maybe there's wisdom within meeting the legislation objectives that didn't quite make it here with this initial response.
That's a good point, and that can certainly be part of our process to continue monitoring these products. We do plan to develop a weekly report that will look at which prescribers are prescribing these therapies, if there's any outlier prescribers, if patients continue to appear to have appropriate diagnoses, or if they have off-label diagnoses. So that can certainly be part of our process to monitor this class.
But I think that's also, you were talking about informationally understanding the other people who have more experience with what they've seen with Project Impact, which is you might be interested in.
Something else
that
that
would be really interesting.
Something else that the committee might be interested in is the Mental Health Clinical Advisory Group is taking an interest in MAT and the appropriate substance use disorders. So as we collect information on that side, I'm sure that it will funnel up to you.
Yeah, I just don't know. Maybe we have to take action maybe because of the timing, but I don't think it's good practice on a subspecialty like this to take action without talking to people who work directly in this space. So I don't think that's a big principle.
Yeah, I think the action is fine, and I also think it's mandated, but I do think it would be pretty interesting to hear a little bit more from the prescribers. Seeing that in the field as it were.
And I have some colleagues who are the Associate Medical Director at Blackburn Center, which is Central Study Concerns Co-occurring Substance Use Program. So, if you need additional names, have a handful.
And I do recall when we presented this in January, we had quite a bit of written comment prior to this being presented, so we could go back and look at some of those providers. Basically, they were advocating that we not have PA criteria for MAT, and that's the purpose of what we're presenting today, is pretty much to remove most of the restrictions.
Right. But with that, I think it's also incumbent on us to understand what is actually happening, because we may learn, in this process that like some of these are more effective at sort of continuation of therapy, and some of them are less effective. So, the question is what's the outcome in terms of the impact on providers, but also in terms of the way that the patients are accessing and using the treatments. Because, if they're not having the desired outcome, then we should question what's the right approach.
And I will say, as a provider, I would like all medications to not have a PA. But as a committee member, I think that Colin's right. Being able to push people towards more effective. And I will also say that I think this is a class of medications that initially was used among a subset of prescribers, and the people who had their X waiver from DEA was fairly small. But now you have PCPs in a lot of communities with it, and so I think it becomes a lot more important when we follow how these are being utilized, and so that we can provide better guidance to people without the expertise.
And again, the legislation was written at a pretty high level, so it affects all the medications. That's what we're doing with the recommendation in front of you. We will continue to monitor this, but appreciate your comments to go out and solicit additional input. If there are any other questions for Sarah Deanna, we do have public comment. No other questions? Then first I'd like to invite up Paul Thompson with Alchemist. Again, just a reminder, public comment will allow you up to 3 minutes of public comment. I'll start to hold up a sign and say there's 1 minute left, 30 seconds left, time's up. Again, please, try to address the comments of the committee. Yeah.
So thanks, Roger. And I cover Vivitrol, opioid antagonist treatment option, and I see there's not really a topic of discussion.
You can go grab a seat.
Oh,
I hear you.
okay.
Plug in the electrodes just so that I can get
Oh yeah, we can get the flash in the eye. I wanted to give the time back to the committee unless anybody had questions specifically about Vivitrol.
We removed all the PA requirements for Vivitrol about 2 years ago.
Right. Just checking if there's any other questions. So, all right. Well, thank you.
Perfect.
Thank you.
And then we also have a familiar face to me, Ann Wheeler. Ann is with Antidepressant. Welcome.
Thank you. This is my first time on this side of the table, so you're going to have to forgive me for anything that I do wrong. So I am representing Sublocade. So if there are any questions the committee has, I'd be happy to address those. Otherwise, I'm just going to provide you with a couple of bullet points of new and updated information. Nothing from the package insert, but something that I wanted to make sure that everybody was aware of. The reason why Sublocade came to be was the fact that there was research that's been published that's identified that there is a threshold concentration of buprenorphine that must be present in order to minimize and eliminate the subjective effects of opioids. And so that's why Sublocade was designed to meet and exceed that threshold of the 2 to 3 nanograms per ml consistently across its full dosing period once it's at steady state. So that's kind of why Sublocade came to be as a long-acting injectable subcutaneous buprenorphine product. I also wanted to share that we continue to collect data on our clinical trial participants through our RECOVER study. So we have a couple of publications that have been released related to RECOVER, and the 12-month outcomes will be coming. They've been presented at 2 national congresses so far, and we were thrilled to be able to present the fact that there are 50% of clinical trial participants who demonstrated complete sobriety at 12 months after they left the studies. So they were completely, some of them continued on Sublocade, many of them no longer had access. Similar to one of the programs that's here in Portland was one of our clinical trial sites. They no longer had access in the state of Oregon, so despite that, after 12 monthly injections of Sublocade in clinical trials, at 12 months post the last dose, they were still demonstrating sobriety. So that was some exciting news. So we definitely support the elimination of prior authorization for all formulations of medication-assisted treatment. And this is consistent with the recommendations that come from the National Academy of Medicine, as well as the Academy or American Society of Addiction Medicine. And it truly represents the best interests of patients and the families who care for those patients who suffer with OUD. And we hope that the Oregon Health Authority continues to work with local CCOs to ensure patient access and parity access to quality care through the minimization and elimination of barriers to these treatments. Thank you.
Any questions for Ann?
Perfect. Thank you.
Okay, so the recommendations again in front of the committee are to make no change to the PDL based on the clinical evidence, but we are recommending removal of PA requirements for all opioid use disorder products, with the exception of leaving in a requirement that anything exceeding 24 milligrams of buprenorphine will deny for prior authorization. We also plan to review these products in executive session, but at this point, preferred products will be designated as preferred, and non-preferred products will be switching over to voluntary non-preferred, so it doesn't run the FDA. And then finally, we'll continue to monitor the use of the products, assess the potential changes in medically scoped appropriate use, and then we have some takeaways to check with OHSU, echo from that, best practices and projects. Sarah?
Just as a reminder, the changes to the PA criteria are both in your packet and in the slides. And so basically, removes all the questions except still addressing that patients that are over 24 milligrams per day.
Again, that's starting on page 104, I believe, in the packet. Questions about the proposed changes for PA?
Any questions from the committee? Okay. We have a motion to
I'm sorry, I do have one question because I'm not sure. Agency approval of those products are the same or no?
We don't ask about age. So
But some products, I presume, are approved for some age groups and some are not. So we have a question on that in terms of like, well, Medicaid is actually not supposed to pay for things that haven't gotten FDA approval.
or supported by Compendia. Yeah. And in this circumstance, we don't ask that question. If it's something you'd like us to look into, we certainly can. We can't do anything in the first 30 days anyway. But
And there are REMS programs, if you recall.
Yeah, I know. I don't know if the use of these new medicines in younger kids is necessarily the most appropriate approach, given that we don't necessarily have data on safety and effectiveness.
and when we look, when we're monitoring this class, we can certainly look to see if we have utilization rate of lower levels.
That's what I would advocate for more than anything else. Is we need to understand what's actually going on.
Definitely. Yeah.
Challenges get the data and information, we can't actually make any or implement any changes to that because it's been legislatively mandated how this class of medications will be handled for utilization.
Well, there's a difference between having a prior authorization and having this is not a covered benefit. Because if it's off-label use, it's actually not a covered benefit. If there's other products that are available that are covered. So that's not a prior authorization. That's an appropriateness of use.
Yeah, FDA approved or supported by the compendia. There's also comorbidity whether or not it's covered in it. So,
right. Yeah, but I don't know.
But we can definitely go look at the data to see if we even have any utilization in SNAT.
Right, and I don't know if there's 7-year-olds who were on these.
Suboxone.
Yeah, right. And I hope not, but or even an adolescent who had a few months use of opiates, it may not be the most appropriate thing to jump to medication-assisted therapy. There may be other approaches we can use.
For sure. I took a note and we'll take a look at that when we want. Thank you.
All right, so we have a vote before us. We have a motion?
Second.
Okay, so the motion I presume is to approve as
Motion
presented.
to approve as presented, yes.
Okay, so we have a motion and a second. All those in favor? Aye.
Aye.
Any opposed?
I'm opposed. I don't think this is evidence-based medicine.
Okay, so we have one opposed, and then we also have some direction to bring back information specific to pediatric use patterns.
Well, and also the use or the continuation of the treatment based on the formulation and product that's being used. If there's some specific parts of how there's a discontinuation, then that's probably not
If there isn't discontinuation. One of the confounders there is that this does also treat some of the pain. So if someone has opioid use disorder and pain, continue to have pain, they're going to continue to need the pain control, and that's the product being used. But again, it's hard to glean out of the data.
Exactly. I think that may be what Jim is talking about too.
Sure.
That we don't necessarily know exactly what we're doing.
Good. But I know we're all taking notes and we can bring to the thing. All right. Staying on course, we'll move over to the antidepressant use in children. Direct you to page 111 in the packet and turn it over to Sarah.
And so this is a topic that the committee had asked us to look into. And as you're probably aware, there's very limited evidence for use of tricyclic antidepressants in children. A lot of the guidelines actually recommend against use of tricyclic antidepressants in children because of the limited evidence of benefit and safety concerns associated with their use. So they do have box warnings for suicidal ideation in children, as well as having a narrow therapeutic index. And so because of those concerns, we looked at what our utilization of antidepressants was in children. And overall, we have a small portion of patients that are actually prescribed tricyclic antidepressants. So the majority of our patients were prescribed SSRIs. So this data is antidepressant use over a year-long period, and we identified about 15,000 children who were prescribed antidepressants. By and large, the majority of prescribers were pediatric physicians, which made up about 25% of prescribers, and then prescribers with a mental health specialty, which was about 38% of prescribers. Looking at tricyclic antidepressant use specifically, they were most commonly prescribed in adolescents, 13 to 18 years of age, but there were 245 children under 12 years of age who did receive a tricyclic antidepressant. The most commonly prescribed TCAs were amitriptyline and imipramine in patients less than 12 years of age. And imipramine does have FDA-approved indication down to 6 years of age for nocturnal enuresis. If we're looking at the FDA-approved indications, which are on the table on this slide, The most common FDA-approved indications were anxiety and panic disorder in about 25% of kids, adjustment reactions in about 20%, depression in 15%, and then miscellaneous other FDA-approved indications were present in about 20%. It is interesting that we couldn't identify in the claims data an FDA-approved indication for about 48% of the kids prescribed TCAs. So these are some of the most common off-label diagnoses in children that were prescribed a TCA. And some of the migraine and headache disorders kind of rise to the top of the list. About 65% of patients were treatment naive, meaning they didn't have any other antidepressant therapy in the prior 4 months. That is a little bit concerning considering these are typically not first-line therapy for any condition in kids. Only about 34% of patients were prescribed short-term use of tricyclic antidepressants, so less than 30 days of therapy. And about 65 to 76% did have an average dose that was less than 50% of the maximum FDA-approved dose. So even though the majority of these children even though these children have claims for TCA, the majority are prescribed a low dose of a TCA. So the proposal we have in front of you is to implement a safety edit for children who are prescribed a new start TCA that is below the FDA-approved age limits. So this would screen out anyone that's on ongoing TCA therapy already, so just targeting those new starts with the goal of preventing off-label use unless it's prescribed by or in consultation with a specialist. We would auto-approve requests from mental health prescribers in patients with a recent claim for an SSRI, which would indicate the TCA is being used as a second-line therapy, and in patients with a recent claim for a TCA to avoid interruptions in therapy for patients that already have established therapy. We did get input from the Mental Health Clinical Advisory Group on this policy proposal, and they actually recommended against implementation of the safety edit at this time due to the following concerns. So they did recommend we solicit input from specialists in pediatric psychiatry and pediatric neurology because it does look like the majority of off-label use is for headaches and migraines. We haven't heard back from the pediatric neurologist that we reached out to. We did get input from a pediatric psychiatrist that had recommended we further stratify and try and identify some of the highest risk patients a little bit better for this population. The Mental Health Clinical Advisory Group also recommended we evaluate the number of unique prescribers that were involved in prescribing TCAs for the children that were less than 12 years of age. And we did look at that and identified 159 unique prescribers for the 245 patients. So the majority of prescribers are prescribing to a single patient. There are a few prescribers that prescribe TCAs more often, but those prescribers are more often specialists as well, with a pediatric, psychiatric, or pediatric neurology specialty. They did have concerns with using a point-of-sale pharmacy restrictions as an initial policy to change prescribing habits, and requested that we consider other types of initiatives such as targeted prescriber education rather than implementation of a point-of-sale safety edit, since this is a relatively small population. And then also had concerns regarding interruptions in therapy for patients that were new to Medicaid for which we don't have that historical claims data to indicate whether that prescribing is appropriate or not. They can ask us to consider allowing a 30-day grace period before the safety edit is implemented. Some of these things are difficult to do with the system that we have, but they wanted to voice those concerns. So knowing that our proposed policy is to implement a safety edit and the Mental Health Clinical Advisory Group recommended against implementation of the safety edit as proposed, we wanted to get your input on this proposed safety edit. So it's on the screen now, and we basically ask if the dose exceeds the maximum FDA-approved dose or if it is not for an FDA-approved indication, that it be prescribed by or in consultation with an appropriate specialist for the condition. And then if those criteria are met, it can be approved for 6 months.
This actually be like a prior authorization process, or would this be overridable, like at point of sale by the pharmacy?
It would not be overridable at point of sale by the pharmacy.
We can do safety edits. We can't stop a drug to say we switch to a preferred product. Can't, PA for PDL purposes. We haven't done a lot of PAs for safety edits for clinical safety reasons, but we do have the authority.
And they're not using it for marijuana. That's the other thing.
Right.
They're using it for things that's not
No, agreed. I'm just like, it's
safe
put
to
the edit in for managing use for not mental health, but also things that are there for mental health as well. You can differentiate those. So
I've got a question on the data. Is there data that supports that these are dangerous or toxic, or is it simply that there's no data on safety? Because if we've got an older drug here that's been around forever, and there is probably no incentive to study it.
Mm-hmm.
So is it lack of data or actual data that's harmful?
There is data specific to migraine.
But it's dangerous.
Is there an issue of it being harmful? I know this stuff is very harmful in overdose, and it's not very pleasant to take, so it is something else.
And we know that, so
if there is data that says it's not effective, that's typically okay. So that supports our position.
yeah. Mm-hmm.
Goodbye.
Yeah, we do have a study in migraine that says it isn't effective alone. It may be useful when it's used in combination with cognitive behavioral therapy. When we looked in our population, we didn't identify any difference in patients prescribed TCAs versus other antidepressants that had any indication that they had more frequent ER visits or hospitalizations, but that doesn't capture all adverse events either.
So right now, if they want a renewal, it would just automatically go through without even being checked. But we're hoping to get some safety edits in place in the future. So this is a continuing cycle of those patients being on these.
But the safety edit would actually effectively only prevent new patients who are not being seen by a mental health prescriber from starting therapy. At least the way things currently. I don't know that necessarily we should say if you're a mental health provider that you should get a pass for starting with TCA, especially in a treatment non-indication. But that's my own personal opinion. Because I feel like I do at least as well with the stuff that I'm treating. I don't treat everything. I wouldn't treat enuresis in a 6-year-old, although that's approved. Because enuresis in a 6-year-old is normal, not unusual. But according to the guidelines here, it says, well, that's okay to do. But we do know that there are significant risks for toxicity and overdose, and we don't have ways to make sure that that doesn't happen. With a small basic population that are using this medicine, it's hard to sort of discern whether or not there's any events or not. And then there may be some subclinical things, irritability and some other kinds of stuff that go along with it, that you can't tell just because nobody seeks care for those issues. Or they may not recognize even that it's connected to medication. So,
the overdose risk is very large compared to the overdose risk of other antidepressants.
Absolutely.
So I'm rethinking what I'm saying. Perhaps this isn't something that this should be very limited to a very small number of folks supervised by people on the streets.
Is there a limit on the day supply of this expense?
34 days supply, just can't exceed this for this therapeutic class.
depending on the kid limited in the dose, though. That doesn't take very many to have somebody to research on it. Or some arrhythmias.
Other comments or questions for Sarah?
Yeah, Les, you're on.
Yeah, you know, I hear what you're saying, but as a provider, those are the things that are part of my evaluation, right? And so, we have data that the majority of prescriptions are for less than the FDA maximum dose, which is good. Which presumes that they are doing at least some management of dosage. Whether that's to avoid potential for overdose, I don't know, but. Given that 60% of prescriptions are by pediatricians, psych nurse practitioners, child and adolescent psychiatry, or psychiatrists, I feel like these are people, for the most part, who probably know what they're doing. Then there are, a fair number in here that may not. Students in an organized healthcare education training program.
Yeah, it's hard to tell. Like, what is that? Isn't that hard to imagine? It's like, oh yeah, let's go to this medication category that we really haven't had a lot of use for in more than 20 years.
Right. And I would love to know, and for the 1% that are being prescribed for bipolar disorder,
which is an incredibly bad idea.
It is an incredibly bad idea. But yeah, honestly, I feel like it's.
That's the research that I accomplished. They're doing that and trashing it.
Right, yeah, something that's less, assuming the patient actually has bipolar disorder, something less likely to actually have a sleep episode. But, honestly, I think in terms of managing what the prescribers are doing, the utilization is fairly low. It's about 300 people who have non-FDA-approved indications. And 60% of those are prescribed by people who I would assume
will get no FDA approved indication. It could be that we just didn't see it on the claims history to capture it.
Right.
So the encounter data might come in and we just didn't see that they, on that office visit, reported it, so we can capture that data.
Okay. Yeah, like I said, I think to me the numbers don't look terribly alarming just in terms of who's prescribing it and how much they're prescribing compared to the SSRIs. I'm a little surprised with SNRIs
that are
not higher compared to TCA.
I think SNRIs tend to be pretty much just in the mental health prescriber. I think that most primary care doctors are avoiding, at least for kids, SNRIs because there's not a whole lot of data, and there's a whole lot of data for SSRIs.
Yeah.
And they prove, have a long track record of usable stuff.
Yeah.
Even an overdose.
Right, sure. Yeah, it's hard to overdose on this alone.
So are you moving to approve the safety edit or moving to amend the safety edit?
I think the safety edit is. I think the safety edit is fine, and I actually ran this past colleague of mine who is a child and adolescent psychiatric practitioner, and he thought it was fine as well. So double comment. So I like the safety edit. I agree. If we could do a 30-day grace period, I think that'd be awesome, but we can't. Then I would say the safety edit is fine with me.
Would it be worthwhile to implement some type of lettering campaign along with this safety edit to notify prescribers of patients that have a denied claim with no follow-up? So they get a denied claim that we see for a TCA and don't have a subsequent claim within the next 2 weeks. Would it be worthwhile to send that prescriber a letter letting them know that?
I would say yes. I would also say that it would probably be worthwhile in terms of like the educated knowledge to address the use of atypical antidepressants, TCAs, SNRIs, and SSRIs as a whole in the group of kids. years long.
Yeah, I mean, I think it's helpful. I mean, I think a lot of the educational information ends up going in a shred box. But I mean, if it helps anybody, then I mean, I think it's worthwhile. And honestly, the best denials to me would be ones that recommended an evidence-based treatment. But I have a way of.
We don't see the diagnosis on the plane, right?
To move this along, may I move to approve?
I have one. I can get a quick question. Sorry. So are we defining children as less than 12 or less than 18?
So what the safety edit would be applied to would be anything that's less than the FDA approved age. So it differs based on the drug.
Could be less than 12, could be less than 6, or
So we have a motion on the floor, I'll second it. All those in favor? Aye.
Aye.
Any opposed? Okay.
So we also heard to complement this with a 2-week post-denial, no subsequent claim follow-up letter. I have one additional question, and I assume the answer, but let me make sure. Grandfathering. Right. This is, as written, this is initiation. We're just talking new starts here. Yeah. Okay.
Can I do it? Go back really quick.
Yeah. Can you do what?
Okay, go back.
You just did.
Okay.
Go ahead.
I just queried all the buprenorphine prescriptions 2019, fee-for-service Medicaid. There were 4 scripts out of 6,100 paid claims. There were 4 scripts for 1 4-year-old. And there was 1 script for a 17-year-old, and the rest are 18-year-olds.
Yeah, and Suboxone is approved for anyone over age 16.
Not really sure about the 4-year-old.
Yeah, that's a head scratcher.
Yeah, well,
Yeah, and it's 4 scripts all in the same month, a week apart. I don't know.
So I'm guessing they were doing week ones. Still, 4 is well.
and
Right. Thanks, Rich.
And I just queried the FDA adverse events reporting system for adolescents and children. And checked it. And people prescribing it to them for things like cyclical vomiting,
right.
fibromyalgia, depression, influenza, migraine, etc. So what that's serious cases, that's true.
Yeah, and I think, I mean, a lot of that is people who know that they're used in adults and for things like migraine and fibromyalgia.
Right. So they just
use them in kids also.
Yeah, the problem is that kids are not just little adults.
It's true.
Right.
Very true.
fibromyalgia may be better.
But still a low number. Thank you,
Right.
Rich.
Okay,
Moving on.
Thank you.
We're next turning to page 125 of the packet for the Dupixent PA update, and turn it over to Deanna.
Okay, dupilumab, the drug that just keeps getting new indications. So we reviewed dupilumab at the July 2019 meeting, and if you recall, we were talking about the recent approval for dupilumab in severe asthma. Well, in June, dupilumab received FDA approval as add-on maintenance treatment in adult patients. Oh, can we switch to the dupilumab slides? There we go. Yay. So it received approval as add-on maintenance treatment in adult patients with inadequately controlled chronic rhinosinusitis with nasal polyposis. So the first question was, is this even funded? And yes, it is. It's a funded condition on line 463 of the prioritized list. So the first paragraph in the background talks about what chronic rhinosinusitis with nasal polyposis is. As it sounds, it's an inflammatory disease of the nasal mucosa, which causes symptoms of nasal obstruction, decreased sense of smell, facial pain, headache, and runny nose. So first-line therapy is nasal saline irrigations, intranasal corticoid sprays, and systemic corticosteroids for acute exacerbations. And then if patients don't get relief from that, they can progress to having sinus surgery. So not surprisingly, there's a couple of biologics that have current studies going on besides dupilumab. So omalizumab, mepolizumab, and resilizumab, the other biologics that are approved for severe asthma, are currently being evaluated for chronic rhinosinusitis. So, let's see. So the evidence supporting this expanded indication, one randomized double-blind placebo-controlled study was submitted to the FDA for approval. Patients were randomized to receive sub-Q dupilumab versus placebo. It's pretty small, only 60 patients total. And dupilumab is not indicated as monotherapy, so they also continued the steroid nasal spray. So the primary endpoint was the change in bilateral endoscopic nasal polyp score, which there is no minimal clinically important difference for the nasal polyp score that's been established. What they were looking at was a change. Any improvement is what they were looking for in this trial. So you can see the results here is there was a decrease of 0.3 in the placebo group and a decrease of 1.9 in the dupilumab, which was statistically significant. Without knowing the minimally clinical important difference, it's difficult to say was that clinically significant, have that change. There was two other trials that were subsequently published after the FDA approval. So these were larger trials in more centers, and the trial design was similar. They were double-blind, placebo-controlled assessment, and their inclusion criteria was very similar to that first randomized controlled trial. And they basically showed that there was change in the nasal polyp score, similar to the randomized controlled trials. And again, that visual analog scale for nasal congestion severity was 0 to 3. Dupilumab has not been studied as a monotherapeutic agent. It's always in combination. In terms of safety, interestingly enough, they saw more nasopharyngitis in the dupilumab-treated group. Injection site reactions is not surprising because it is administered subcutaneously, and headache. The caveat with this is these trials were small trials with limited duration, so we don't really know what the long-term effect would be when this is used for treatment of the chronic rhinosinusitis with nasal polyposis. These studies were also funded by Sanofi and Regeneron. The manufacturers in collaboration with the academic clinical investigators provided input on the design and conduct of the study. They oversaw the data collection, management, and statistical analysis, and they contributed to the interpretation of the data as well as the preparation, review, and submission of the manuscript. So they were substantially involved in the trials. So the recommendation is to revise our PA criteria for dupilumab to include the FDA-approved indication. The PA criteria are on page 128. If you want to take a look at what we have for dupilumab. So I just highlighted what the changes were. So in question 6, we will make sure that they're being seen by a otolaryngologist or ENT that is specialized in evaluating nasal chronic rhinosinusitis. And then we added question 14 was to make sure that they have that diagnosis of chronic rhinosinusitis with nasal polyposis. And then question 15, make sure that they at least try 2 or more courses of immunocorticosteroids before they advance to a biologic. And then in the renewal criteria, we added have their symptoms improved after they get dupilumab. So the initial recommendation for approval was for 6 months, and then after 6 months we would reevaluate if continued therapy was warranted. So any questions about the evidence?
Yeah, I have a question about the evidence on studies that were done that's sort of more extensive. The
Liberty trials?
Yeah. For those, did they look at the rates that people had to have treatment for acute exacerbations with chronic sinusitis? You know, the differences between the placebo group and the control group, or was it based on like reported symptom scores that were taken at certain points in time?
They were using pretty much the same outcomes. The concurrent primary endpoints were the change in the endoscopic nasal polyp score and the nasal congestion severity. So I didn't do an evidence table for these studies, mostly because this is just an expanded indication for dupilumab. I think we talked about dupilumab this third time this year that we've talked about it. So
we don't know if the people who were on dupilumab actually had less use of oral steroids.
No, they didn't.
So we don't know that was a thing. It's
Right.
mostly just based on the.
Yeah, they were just looking at the improvement in nasal congestion. I can definitely go back to these trials.
We also have public comment. They might be able to answer that for you.
Yeah.
The other point was the change to the thing. Failed medical therapy with inhaled corticosteroids. Shouldn't that be intranasal?
Yes.
And do we actually cover at the OHP level
With PA.
Okay. So you have to get a PA to get an intranasal steroid. Which costs $6 a month. Right?
And what would we consider two or more courses?
Well, what I took that from the guideline note that they use that HERC uses for surgery. So we could be more explicit about what we do by that if we want.
I was curious. I think it's probably more than 30 days. I think usually when I'm seeing notes from the ENT folks, for when they want them to come back for follow-up, it's usually at least 6 weeks. So I think 2 or 3 months is probably a reasonable amount of time to have trial nasal steroids before you move on to something more aggressive. I mean, the only kids I've ever had these kinds of conditions, it takes like a year and a half before they finally get to, the decision on whether or not to do, surgery or whatever. It's a very long process.
So did you want to define that in the PA criteria or leave it as 2 more courses?
The pharmaceutical has been defined the duration.
Yeah. And I think it makes it easier for the viewers. Very rich.
Yes.
I would think so.
Yeah, so we can add that. I'll look up what's considered an adequate course and we'll just revise it.
Sounds good. Kind of on that same line, I was wondering if there's any ask for patient symptoms that improve, but do we have any objective measures of that?
Well,
or is there
like I said, what they used in the trial was this
not measurable?
right.
So
Yeah. So but basically they were looking. The physicians grading the polyp size, so they were looking and they reported it as the sum of the right and left nodules with a range between 0 and 8. So it's I think it's more of a subjective assessment by the physician to say are there symptoms.
And then there's the other, congestion. Right, congestion was also.
Yes.
Which would be a little easier to assess.
Yeah, nasal obstruction. Yeah. Well, and in order to be enrolled, they had to have nasal obstruction, facial pain and pressure, or loss of sense as well. So change in symptoms, feeling better, would also be subjective.
and this one has an age limitation.
Adults. Yeah.
So should be able to be
It's in that table, right? The indications and ages are associated in the table.
Yes.
Right, you only have this criteria, it doesn't include the table, that would take. 3 pages. I know what it takes, but it's already in the PA criteria. It's just another add-on. That would be confusing because there's so many. Any other questions for Deanna? We do have public comment again. All right, we have Brandon Yip with Sanofi Genzyme. Yeah, Brandon, you have up to 3 minutes. And I don't know if you heard the question at the beginning, but if you address that, that would be wonderful.
Yeah. I'm just going to give the time back to you guys. I mean, I had some stuff that's prepared, but I would love to answer any questions that you guys have that I can answer.
Well, the question was there a difference between the test of the placebo group in the trials in terms of the treatments or the number of episodes of acute exacerbations that were on sinusitis during the 24, 28 weeks of the studies?
So number of episodes, I don't remember that from the data, but the data did capture if they needed, if there was an exacerbation to mirror like what real life would encompass, they were allowed to use rescue therapy, systemic corticosteroids, and if a hospitalization was needed, it was recorded. So if you want, I can probably get that data for you.
But probably not before we go.
No, unfortunately. But Dana did a great job of summarizing everything. What I can just expand on a little bit is like the NPS score. That is an objective. I heard some comments about the scoring, and that is an objective score. It's just based on endoscopy by ENT. So it's counting up basically the number of polyps and the number of polyps and the size of the polyps is leading to that nasal congestion. So the nasal congestion score is a subjective score, and that's based on the patient evaluating how bad that is. So I heard some of those comments.
Thank you.
Good?
Appreciate it. Yep.
Thank you.
So again, the recommendation in front of the committee is to revise the dupilumab PA criteria to include chronic rhinosinusitis with nasal polyposis as an FDA-approved indication for dupilumab as an add-on therapy to standard of care, with the PA criteria changes outlined on the slide.
I just want you to say chronic rhinosinusitis.
Once, exactly. I got close the first time I stopped.
You get to clarify the courses. Yes.
Right?
Clarifying the course of steroids and change inhale to yes. So
as amended.
It would be as amended. Is there a motion? Motion to approve as amended. Okay. All those in favor? Aye. Aye. Any opposed? Any abstain? Okay. Motion passes.
Keep pressing on. We're turning to page 134 in the packet. For the rifamycin new drug evaluation. We have deferred this for maybe 5 meetings, so I think the drug is almost off patent. Over to Sarah.
So just as a little bit of background, there are guidelines from the American College of Gastroenterology out there from 2016 that actually don't recommend empiric treatment of antibiotics for traveler's diarrhea unless the likelihood of bacterial pathogens is high enough to justify the potential side effects of the antibiotic. And these are the recommendations from the American College of Gastroenterology. The currently recommended treatments include fluoroquinolones, erythromycin, and rifaximin. Currently, we only have PA criteria for rifaximin, which restricts use to funded conditions such as the prevention and treatment of hepatic encephalopathy. And traveler's diarrhea does fall on a funded line under infectious diarrhea on the prioritized list, so it is also classified as a funded condition. This new drug is indicated for the treatment of traveler's diarrhea, which is caused by a non-invasive species of E. coli in adults. Rifamycin is similar in mechanism of action to rifaximin, and similarly to rifaximin, it's poorly absorbed when it's administered orally, so mostly stays in the GI tract. It was studied in 2 separate studies which compared it to placebo and ciprofloxacin. You can see the results of these studies here. Compared to placebo, there was an improvement about of about 22 hours in the time to the last unformed stool with rifamycin compared to placebo. It was non-inferior to ciprofloxacin based on the study by Stephan et al. You can see the inclusion criteria for each of the studies here. They were primarily studied in adults who were traveling from industrialized countries to Mexico and Guatemala in the case of the first study, and I guess of interest, the second study did exclude people who were traveling from the U.S., so that limits applicability in our population. Some of the trial limitations included how they defined the primary endpoint, including time to last unformed stool, and then also one of the secondary endpoints, which was clinical cure. So based on these definitions that they used in the study, patients could still have symptoms after those time points. In addition, there were concerns with incomplete diary recordings, leading to missing data in their primary endpoint, the time to last unformed stool. And then, again, applicability. The first study, which compared to placebo, was primarily applicable to travelers in Mexico and Central America, and the second study excluded travelers from the U.S. As far as safety goes, the most common adverse events associated with treatment were headache and constipation, which occurred at greater than 2% compared to placebo or ciprofloxacin. Constipation occurred in about 3.5% of rifamycin compared to 1% in the placebo group, and similar rates for headache in the second study. And so the recommendation is to designate rifamycin as a non-preferred agent on the PDL and add it to the PA criteria for rifaximin to ensure that it's used for appropriate indications. And so this outlines the changes to the PA criteria. So these first 4 questions are the questions that would be newly added to the PA criteria. And they outline our basic questions that we ask in all PA criteria. So the diagnosis that it's treated for, if it's FDA approved and funded, if it's indicated for traveler's diarrhea, making sure it's approved for only 3 days and asking if they'll switch to a preferred product, which would include fluoroquinolones or azithromycin. Questions?
Should we add in there the reason as bloody diarrhea or fever?
We certainly could. Because it is indicated for traveler's diarrhea, often patients fill their prescription before they actually have it.
And on that note, the Pharmacy Formulary Advisory Committee has included travel medicine as a category that there will be pharmacists prescribing rules associated with. And so there is the possibility that pharmacists will be able to prescribe medications based on the protocols that are developed. Right now, that's pretty much just azithromycin. So, I don't know if the addition of this product will impact any of the protocols at the prescribing pharmacist level or not. But I just wanted to share that. The pharmacists are not going to be prescribing Cipro.
But the way the criteria is written right now, we don't know that it's caused by a non-invasive strain of E. coli that's being prescribed in advance.
Right.
So how would we cover that?
And the way that I would anticipate it would happen is if they're traveling to an area where they're likely to pick up a non-invasive strain of E. coli.
Should that be part of the criteria, like when they travel in advance?
We certainly could add that.
Or reserve this for treatment upon return?
Well, I think that may be what ends up in this situation. I mean, people do go and have to come back early because of,
Non-formed students.
Right. Yeah. I actually, that just happened to me. So,
as one who has experienced this on several continents, you want someone to have a safe and effective medicine with them when they come. And if you're going to London, you're not going to like this. And so we want to steer people to the most economical of the long existing, very safe, very cheap medicines. And if you're lucky, I have some Cipro tablets that have been a lot of places. They've been updated to azithromycin due to my last trip, but not everybody who travels uses these, but we want people to be prepared. So I would scratch the E. coli thing. People aren't going to buy something to go somewhere without eating, which is a good portion of the plan.
So are you saying it would be self-limiting to say who might prescribe this in advance of a trip, depending, because it's saying like the pharmacists that are going to be traveling, prescribing for travel medicine aren't going to prescribe it.
Well, it's one part of the program.
Understood. So it would be a provider that's more familiar at this age and knowing where their client is traveling to, that's probably more appropriate.
And I think if this costs what I think it's going to cost, it's going to be the fourth choice. Based on, because the efficacy is very similar, and why, trips cost as much as it is.
It's so interesting too, because isn't there like an administrative rule that limits coverage for Medicaid for travel vaccinations and travel medicine? So
With UNJ, I don't know that.
I would just question whether.
And I know we don't cover travel vaccinations specifically.
So it's like in that same category, or should it be considered the same one?
Well, I feel like the cost and potential coverage would limit its acceptance by patients. If I showed up and found out that my, prophylaxis or whatever, my treatment option was going to cost me $400 or whatever, I would call and say, is there a cheaper option? So, I don't know.
But if you're
that's not ours.
If you're an open heart Medicaid patient, it costs $0.
And I think we do have to provide an option for people who are allergic to that entire class of drugs or have contraindication, because they do have some significant contraindications in this one. So I think we have to have some language that discuss as a patient. Maybe we have to steer first reviews on that.
Yeah, the patient should have medical